Coming up on the Get Lean, Eat Clean podcast.
It's become roboticized, unfortunately.
Yeah.
I can remember the days of seeing my physician, and the conversation would start out by a review of how are you?
Right.
How is the family? How are things? What's going on? And currently, the physicians are under such a quota, such pressure to get so many patients through, that camaraderie, that discussion of life has been lost, and instead, all you're seeing is the back of that physician's head as he or she is typing into a computer and clicking off boxes of completed notes, as opposed to actually engaging eye to eye with you and examining you. Even physical diagnosis has fallen a wayside to lab studies and imaging.
Hello, and welcome to the Get Lean, Eat Clean podcast. I'm Brian Gryn, and I'm here to give you actionable tips to get your body back to what it once was 5, 10, even 15 years ago. Each week, I'll give you an in-depth interview with a health expert from around the world to cut through the fluff and get you long-term sustainable results. This week, I interviewed Dr. Michael D. Young. Dr. Young spent nearly 30 years as a surgeon while living and practicing medicine in Chicago. He's also a best-selling author of 3 books, Consequence of Murder, Illness of Medicine, and Net of Deception. Currently, Dr. Young is on the faculty of the Department of Urology at the University of Illinois in Chicago. We discussed issues with the current healthcare system, lack of nutrition training for doctors, the impact insurance and pharma companies have on your doctor, and why we need to be proactive regarding our health. Really enjoyed my interview with Dr. Young. I know you will too. Thanks so much for listening and enjoy the show. All right, welcome to the Get Lean, Eat Clean podcast. My name is Brian Gryn, and today we have Dr. Michael D. Young. Welcome to the show.
Good morning. Thank you.
Yeah, we were talking offline. We both went to Indiana and are avid golfers. So a lot in common here. And I'm excited to have Dr. Young on the show. Perhaps maybe give the audience a little bit of background, just your experience as a urologist, 30 years as a surgeon, and what sort of brought you to now becoming a bit of an author. So,
Well, I practiced medicine in the Chicago area for, as you stated, nearly 30 years, and I truly enjoyed it. I became disappointed, I guess would be the best word to describe my experiences in healthcare delivery towards the latter part of my practice. Over the past 10 years, as I witnessed a greater debacle that patients had to go through, that providers had to go through in obtaining or providing healthcare, it became increasingly frustrating for me, and I wanted to write about it. And so I elected to step out of clinical practice and wrote my first book, The Illness of Medicine, which was a anecdotal and commentary about the evolution of our healthcare delivery system, which again, I find a great deal of fault in. I always enjoyed medicine. I have no complaints about that. None of the problems were the practice or the patients. It was the environment with which we had to practice. It was the overwhelming bureaucratic control from a corporate structure that was evolving in healthcare. And since I left practice, I was recruited to be involved, and am currently the Director of Innovation in the Department of Urology at the University of Illinois at Chicago. I teach a course there in the College of Medicine and am engaged in designing and developing medical instruments and surgical devices. And since then, I have also written 2 novels with a medical predicate, and am currently working on my 4th book.
excellent. Yeah. And we were talking, your first book was The Illness of Medicine,
Yes.
Experiences of Clinical Practice. What are some of the big takeaways that individuals would get from reading that book?
Well, I think the book starts out trying to explain how I evolved in medicine, both from my background as well as the practice that I was engaged in. And then it divides into more of a descriptor of the problems that patients are confronting. And I would state that the main predicate is that it is the business of medicine. It is
Yeah.
the business of healthcare, who I feel their main objective is sustaining the business of healthcare, and that the patient has become more of a commodity in this transactional relationship with healthcare. The physicians themselves have really lost control of their own domain. They have lost the ability to appropriately manage not only what they're doing, the financial outcomes, but also the process by which patients go through. They don't own their own practices anymore. And so I'm trying to describe for the reader that the providers and the patients are really in the same lifeboat as they are struggling to contend with this overwhelming corporate managed perspective of healthcare.
Yeah, it's interesting you use the word commodity as like the patients are commodities, and it is a business, right? And um almost it's one of those things where they like the healthcare system, do they want us to get better, or do
Well,
they
that's a great point. And I would make the statement, and perhaps it's a broad statement, but the United States is selling disease. We're not selling health. When I turn on television, I'm not hearing a whole lot of advertisements about what to do right for myself. What I am hearing is that we will sell you a pill.
right.
And if you look at other countries that have much more preventative healthcare initiatives, we see fewer patients going to the emergency rooms. We see fewer patients being admitted to the hospital. We have less of the chronicity of disease that we have here in the US, which is really reactive instead of preventative. And so,
Why do you
to
think
your
that is? Would you say that's because just the amount of clout and money within the pharmaceuticals?
Well, I don't blame the pharmaceuticals entirely. I do find them to be significantly culpable for a lot of the problem. If we looking at the pharmaceuticals, the United States makes up 5% of the world's population, and yet 40% of all drug sales are in the United States. 40% of that money is gleamed here at the U.S. I believe 80% of all hydrocodone prescriptions for the whole world are prescribed here in the US. So yes, the pharmaceutical industry is promoting themselves significantly. They advertise significantly. If you look at television,
Oh yeah.
I think several years ago, a study was performed that showed over 700,000 ads on TV for drugs. And it's interesting to note, Brian, that the US and New Zealand are the only two countries in the world that allow medication direct consumer advertising.
Hmm.
So yes, the pharmaceutical industry has a large part in the costs. We think that they contribute significantly to many of the um, uh, people who go into bankruptcy. They simply can't afford their medications. I would
Right.
also put a fair amount, and probably the majority of fault, on the insurance industry. I like to quote, the golden rule that he who owns the gold makes the rules. And the insurance industry dictates the flow of money within
Right.
medicine. I, as a physician, can charge whatever I like, but the insurance industry is going to reimburse me what they deem is reasonable. And their metrics for what is reasonable is not the same as mine. And so I do feel that the uh, insurance industry, which is regulating uh, the great majority of costs, both physician costs, hospital costs, what the patient has to pay out of pocket, et cetera. And finally, I would argue that the corporate structure that now owns hospitals and physicians. Some 45% of practices, some 70% of physicians who are under 40 are managed by a corporate structure. And they are dictating, for instance, to physicians how many patients they need to see, how much they have to do. Um, they're controlling the paycheck.
Yeah, and you don't see many private practice anymore, right? Like it's too expensive, right, to be in
It
practice for
is.
yourself. Is that correct? Yeah.
Yes, I was in private practice initially for 20 years. Um, But with the costs of malpractice insurance, with the inability as a solo practitioner or a small practice to compete with the contracting that occurs um, with various insurance coverage, we ended up having to join a large collaborative group of urologists. There were about 70 of us in practice. It
Wow.
was the second largest group in the United States. And unfortunately, yes, it was a matter of survival financially with that. But unfortunately, I in turn lost my capability of dictating how I would do things. It was a corporate,
Mm,
it was like the Titanic turning, and everything had to go through a internal discussion review, and it became a very
like political almost.
political and
Yeah.
very unpleasant way for me to practice. How I wanted to practice was now dictated by a group decision. And I went into private practice because I had my own visions of how I wanted to proceed. And now I was part of a large consortium, and not all of which felt the way I did about certain things.
Yeah. Yeah. I think that's obviously been the growing trend, like you mentioned. And I think, like yourself, getting into becoming a physician in the first place, you probably didn't think it would go down that road. But a lot of doctors don't imagine themselves going down that road. But like you said, it's almost a matter of survival as far as having a practice and being able to practice the medicine that you've learned over the
Yes.
last many.
It's become roboticized, unfortunately.
Yeah.
I can remember the days of seeing my physician, and the conversation would start out by a review of how are you?
Right.
How is the family? How are things? What's going on? And currently, the physicians are under such a quota, such pressure to get so many patients through, that camaraderie, that discussion of life has been lost, and instead, all you're seeing is the back of that physician's head as he or she is typing into a computer and clicking off boxes of completed notes, as opposed to actually engaging eye to eye with you and examining you. Even physical diagnosis has fallen a wayside to lab studies and imaging. And I'm not saying that um, that is wrong in terms of diagnostic ability, but I also feel we have lost that human component of healthcare, that I, as a patient, I need someone to touch my belly, hold my hand, smile, give me reassurance, and not this roboticized, sterile treatment modality that we're in today, mostly out of efficiency needs.
Yeah, and you mentioned before about like prevention, and obviously myself being in this business as a health coach and just interviewing a lot of different individuals in the same realm. I think prevention hopefully has become more in the limelight in a sense with a lot of different like for example, I'm learning through a company called Functional Diagnostic Nutrition, where you're going to learn how to do some tests on individuals and help people be proactive about their health, because really our healthcare system, or if you want to almost call it like a sick care system, is really just about waiting till that individual gets sick.
Yes. Yes, exactly. And to your point, nutrition is something that I honestly feel was neglected in my healthcare medical school
Right.
education. Um, the value of understanding diet, understanding the gut biome as a major predicate in our overall health was really ignored, and much of our healthcare um, teaching is exactly what you said. It's after the disease has occurred, as opposed to preventing it. When I was a practitioner, as a urologist, obviously I practiced in the era when Viagra came out.
Right.
Viagra was introduced. It was FDA approved in March of 1998. And I remember very clearly how that impacted healthcare. Patients were demanding this little blue pill. And yet, when I would try to tell patients, well, let's try something else. Let's change your diet.
Right.
Let's increase your sleep. Let's cut out the alcohol. Let's cut out the smoking. Let's go on a vacation for a week. All of these measures to try to improve health without taking a medication seem to be an outlier in how many of my colleagues were managing it, because it was much easier. It was much simpler to write a prescription than to go through the litany of discussions about one's trying to lose 20 pounds. And as we look at our society today, if I believe obesity is about 40% of our population, or
Mhm.
overweight, I don't know specifically, that's a bit out of my realm, but we have a society that is not engaged in healthcare prevention, and as a consequence, we're seeing all of these chronic illnesses.
Yeah, and also too on that point is the amount of statins and things that are handed out. Is part of that reasoning just the physicians, the pressure for them to move the statins to make you know
No, I don't think so.
okay.
And I'm certainly not opposed to writing prescriptions. That's what I
Sure.
did.
Sure.
However, um, as a surgeon, for instance, to cut was not to cure. To cut was to cut.
Right.
And it is not the go-to solution that I felt was appropriate. It was the last solution. And the same thing with medication. Certainly, if you need to prescribe it, do so. But I would always encourage trying what could be done without the introduction of these drugs. And it's not that these drugs are necessarily bad for you. However, um, many patients are taking multiple drugs for many things, and I would see, particularly in my practice as a urologist, a fair number of my patients were elderly. Um, I'd see patients coming in on 12, 13, 15 drugs.
Wow.
And rather than adding another drug, let's try to subtract some. And let's see, we're on one drug to compete with or cause one problem, and another drug to balance that drug. And it really became a ridiculous chess match of trying to counter each drug's side effects. So to that point, no, I don't think physicians are encouraged to write drugs, but I think they're very easily ways to help people, and that is the one they do. And I would argue other ways that are much more long-term or time-consuming are less frequently engaged.
Would one solution be because I had a doctor out of the West Coast, Dr. Gary Schleifer, who has a practice and they're geared towards preventative. Would one way of sort of changing the realm around this or the landscape is with the trainings that are being done for physicians to incorporate more of that preventative end in their trainings and make that part of almost like a benefit to having a practice and helping people.
Oh, absolutely. And,
Yeah.
and again, the physicians, 99.99% of physicians are going into healthcare. They're going through a very long process of education and training, a lot of work, a lot of sacrifice. They want to do the right thing. I think many of them are handcuffed right now. They simply don't have the capability in the way practices are set up to facilitate these long-term discussions
Hmm.
With a patient. A current patient comes in, and it's interesting, Brian. A study was done that showed that a patient comes in, and 88% of their time, their introductory statement is interrupted, and it's interrupted at 17 seconds in.
How where do you get this data from? That's
Well, it is.
interesting.
I
Just,
mean, this has
yeah,
been repeated. This is
yeah,
not from a study,
right.
but patients who have been preparing for that appointment for weeks, if not months, have they are prepared to think about what they want to talk about, and the physician who has no time allotted because they are under this quota system because their practice is owned by this corporate structure is telling them, you have to see, 20 patients per day, ding, ding, ding.
Right.
It's very much a roboticized process. The patient is also exposed to more mid-levels in practice, right? Less of the physician's time.
Mm.
I've met some very, very capable and very good mid-levels, but again, um, from my perspective, patients want to talk to the doctor, and the doctor just doesn't have the facility to do it. And so you're talking about preventative motions or preventative means for healthcare. That requires time, it requires emphasis, it requires reiteration. That just doesn't exist today in our current system.
Yeah, and really it just comes down to the individual being proactive and taking their health in their own hands. Granted, there's a time and place, obviously, to go to a doctor, and I'm not understating that, but like even for my own health, like I do my own, I used Merrick Labs. They, got a script right up, do my own labs. I had another individual who I was on the podcast, who is very well versed in analyzing blood, doing blood analysis. And just I've done some talking with him and just going through the blood work and really looking at what are optimal markers for myself. Because a lot of times the marker, even though the ranges that are shown on a lot of the blood work that's being done is not optimal. It's what, like the general population should be at. And so, yeah, it really comes down to a lot of just like you mentioned,
Well,
yeah, go ahead.
yes,
Yeah.
but it's interesting, Brian. You're mentioning yourself or the most people, they don't have the time, they don't have the energy, they don't have the resources.
Yeah.
They are working one, maybe two jobs. They have their children to manage. They have so
No,
many
yeah.
responsibilities that the last thing they can do is to be their own physician. And to that end, many people go online for their healthcare information, and that is a double-edged sword
Sure. Oh, yeah.
because people are learning the vocabulary, but they're not learning the meaning. And so they will go online for 20 minutes, a half hour, after I discuss with them a particular problem. I mean, I've spent 30, 40 years doing that, and yet they're going to go online for half an hour and feel that they have the equivalent background to discuss this. And they don't, obviously. But the internet provides a background information media for them, but it is not replacing. And people who think that are making an error because they don't have the background to properly interpret everything. So yes, you have knowledge, you have experience, but the great majority of people, they don't.
Yeah.
And seeing a doctor is a rare event, and unfortunately, it's all too often after a problem has occurred.
Yeah. No, you're right. I mean, most people won't necessarily go out of their way to, do their own blood work and maybe I think it's important though to align yourself maybe with either some type of holistic practitioner or someone that's a little bit more on the preventative end. Still have the doctor, right? As an annual or biannual sort of appointment, but it also helps to have someone who's more versed maybe in the nutrition and the wellness side of it. I think that in itself is a good sort of 1-2.
Well, yeah, I
Yeah.
mean, things are evolving today. If you look
Yeah.
at just what we can do with the apps on our phone, patients are able to monitor, for instance, their glucose much more easily today with the transdermal monitors as
Right.
opposed to having doing a finger stick.
I have one on
Um,
right now.
so
Yeah.
if you're
Right.
doing a finger stick to check your glucose several times a day, after a few days, after a few weeks, after a few months or years, right, you get tired of sticking yourself. It
Yeah.
hurts.
Yeah.
It's expensive. And you know what? After a while, you say, you know what? I'm not doing it as often as I should. So obviously, the transdermal monitors allow you to more frequently do it and take control where, again, much of our healthcare is improved if we have a consistency and frequency of evaluation. You have the patients who can monitor their EKGs off their phones today. So I do, and I'm hopeful that downstream we will have technology that allows you to measure, say, blood pressure more easily. Um,
Yeah.
all of these things that give or empower the patient to take some modicum of control rather than waiting for that, as you state, annually or biannual exam. The more frequent you can assess things, keep your weight in check, keep your glucose in check, I think you're going to see less downstream medical issues.
Yeah, no, you're seeing a lot that with the wearables, like you mentioned, the CGM, which I do from time to time, just to sort of just to get an idea. I like to test things out, and like the Whoop and the Aura Ring, and where
Mhm.
it analyzes sleep. So yeah, no, I think that is a growing technology that can definitely be used. Um, what would you say? Let's maybe get a little bit into you have a few books. Maybe touch on your most recent one. Is that the novel?
Well, I have written two novels using healthcare as a predicate um, into problems that occur. My last book was entitled Net of Deception, and Net of Deception was really predicated on my frustration as a practitioner with these evolving online pharmaceuticals, um, such as, pardon me,
Yeah, no problem.
such as um, where one can order uh, various erectile dysfunction medications. And as a consequence, uh, I found it very disturbing that a patient could so easily convince the practitioner at these companies of the need for, say, Viagra, and they would get it.
Right.
And they bypassed many of the questions that I think are important. Oh, one could argue that they're licensed physicians, they know what questions to ask. I went on myself to try. I could have gotten these drugs without ever talking to anybody.
Right.
There was very little vetting of my need. And yet these drugs are not benign. There have been deaths related to them. And so I wrote that novel as an expose, if you will, in a fictitious manner, but predicated on reality of a nefarious company that takes that healthcare information that one is giving and uses it as blackmail information. You
Mm.
know, I can go to Amazon, I could go to any online retailer and they'll ask me for my mailing address and my credit card. That's fine. But if I go and they're starting to ask me more uh, delicate questions about my personal health information, well, that's things that they can hold on to and potentially use against me. And so that's what the novel was about. It was about a bad acting pharmaceutical online company taking advantage of people's needs and their weaknesses, uh, and then going back and using that against them. So
Mm.
it's a fictionalized perspective of reality.
Yeah. What would you say? Like, what are some of the biggest things that you learned about just like writing these books, but also your just experience 30 years as a surgeon? Like, would you have changed anything through your career? Um, uh, would you have done anything differently? If there's someone that's maybe getting into medicine, what advice would you give them?
Well, I do teach in the College of Medicine at University of Illinois here in Chicago. I
Nice.
teach a course in innovation and in the development of medical devices, more as a technique or a tool for learning methodology and process.
Okay.
But again, I try to emphasize to the students um, the need to maintain and to find the if there is such a thing, the humanness that has been lost in healthcare. The students are very well versed in anatomy, physiology, et cetera, et cetera. But how do you learn to talk to someone? How do you learn to evaluate, to be in touch with them? And I'm not trying to be Pollyannish here, but we have lost that in healthcare. Um, we all have that image of the physician as this caring um, individual who's listening to our problems, and yet when we go to the office, I think we all come away almost disappointed that I've got a slip of paper with a set of instructions of what I have wrong with me and a prescription and a number to call. And when I call that number, it ends up going to some computerized answering service that puts me in touch with someone I've never met. And so I really want to try the current generation to try to become more involved in treating a person. From my perspective, uh, treating an individual is not treating a disease in a person. It's treating a person with a disease,
Mm.
and understand that that person needs comfort and they need understanding and they also need direction. Um, and they need a human element that I'm finding is missing today.
Yeah, no, that is so true. And I was actually speaking of a company that I think is sort of on the forward end of doing things. A company called, have you heard of Go Forward?
I have
Um,
not.
they're actually in Chicago. I've never actually done anything with them. I'm not affiliated with them, but I was just looking them up, and that they've sort of tried to combine like personalized preventative healthcare and make it all into one. Sort of a cool leading edge company. So yeah, it's called Forward, and if someone's looking for maybe a resource to use, that might be something. And I know they're in
Yeah.
Chicago and a few
No,
different areas.
it's a terrific concept. I see I see two problems. I see, yes, number one, people need to take more control individually. They need perhaps more advocacy on their own. But we also need to find a method of healthcare for the masses,
Sure,
for the public.
sure, right. Because
And
they're paying monthly. This is out of pocket.
right, and
Um,
people can't afford that.
right.
Half of 45%, 50% of Americans right now can't afford a $500 emergency medical bill. Their budgets are so thin, they are not going to spend that extra 10, 20, 30, $50 a month. They just
Yeah,
can't, and they
yeah,
won't.
yeah, yeah. Well,
So the
yeah,
economics of healthcare really supersedes what most people want and need today, right? And we look at this healthcare train that is moving. Right now in the United States, we have the most costly healthcare system in the world. And what are we getting in return for that? Um, we are 30th in longevity. And I'm sure that comes as a shock to many listeners. We all pride ourselves on American technology innovation and look what we have, and yet we're 30th in longevity. We're first in obesity. Uh, 15% of our children are on poverty. Um, these are inexcusable numbers.
yeah. And there's probably not a quick fix, as we've seen, especially with all the
Well,
politics and things like that. Yeah,
no, there isn't, but I think there is a fix.
yeah.
And um,
Maybe you should run for mayor.
well, I do think that this is not a problem that has been forever. I think, and this is something again I experienced over the last decade or so in practice, which eventually drove me out of it. But if we can control, and this was the predicate of illness of medicine, if we could control the flow of money, I think we could better manage things. Now, that's easier said than done, obviously, but we can regain this. If, from my perspective, if you have a single payer system where you're not having competition and you're not having a fragmented healthcare delivery system. Right now, the drug companies are pulling out what they can. The device are pulling out what they can. The industry is pulling out what they can. Nobody is working in a consolidated fashion for the patient. We live in a country with 20 to 25% wasted money in a 18 trillion, we have this massive amount of GDP, of which, 17%, 3.5 trillion is spent on healthcare. 20 to 25% of that is wasted with administrative costs, over testing, inefficiency use of our testing. There's no excuse for that. If we had a single payer system, from my perspective, no one would be competing, they'd be working in a consolidated manner. So I do feel that, without getting too far out on the political spectrum, because healthcare shouldn't be political.
Right.
Healthcare is something we all need. We are all patients, physicians alike. But we do need a method to reel in and control how money is spent in medicine. And I think if we can do that, we would have better control. We could eliminate many of these problems that we have. So I'm not giving up on it.
Yeah.
But how we vote, which companies we support, whose products we buy, which stocks we buy, et cetera, can all control the flow of money. And I think it is a generational problem, Brian. This isn't going to be fixed in a decade. It may take 20 to 30 years, but I think we could get things back on a where the ship isn't keeling.
Yeah. Well, yeah, this is definitely a topic that we could probably talk hours about. But yeah, I appreciate everything you've brought to the show. And where's the best place for people to find you?
Well, people who are interested in my publications, they can go to my website, which is michaeljyoungmd.com. They can go to my publisher's website, which is gmbooks.com. I'm on Amazon. In the Chicago area, there are not a lot of bookstores anymore to find these books.
I definitely want to check them out, because I'm more of a nonfiction guy, but it sounds like it's your novels are sort of a mix of both nonfiction and fiction.
Yes, they are.
Yeah.
And but a few independent bookstores will carry my books. But again, from where I'm sitting, I have to think long and hard where I could physically go to a bookstore and purchase a book. And so online seems to be the most, that appears to be the easiest method to do it. And I hope people will take the time to read these books. They all carry a theme. The novels, as you stated, they are novels, but they're predicated on experiences of reality. Of drug company realities, of drug innovation realities, of problems that people see in healthcare. And my main topic, I guess, if one could say, I see a common theme of greed in all of my books, which leads to many of the debacles that we're having.
Well, Dr. Young, I appreciate it. I will definitely check out. I'll put some links in the show notes of your books and your website. And thanks for coming on the show today. A local Chicago guy, and IU looks like their basketball team's going to be something to watch this.
They're looking good
season. So thank you so much for coming on the show.
Great, Brian. Thank you so much.
Thanks for listening to the Get Lean, Eat Clean podcast. I understand there are millions of other podcasts out there, and you've chosen to listen to mine, and I appreciate that. Check out the show notes at briangryn.com for everything that was mentioned in this episode. Feel free to subscribe to the podcast and share it with a friend or family member that's looking to get their body back to what it once was. Thanks again, and have a great day.